This podcast is part of the Big Heads Media Podcast Network. Go to bigheadsmedia.com for more great podcasts.
Today's episode, we spoke with Stephen Mays, a medical laboratory scientist who specializes in microbiology and molecular diagnostics. We talked about COVID-19 testing, viruses, and accurate information.
Hi, I'm Eric.
And I'm Isla.
And together we are the hosts of the BiCurean podcast.
BiCurean is our answer to the polarizing culture we live in.
Tired of feeling under siege and looking for ways to get involved? Then come be a part of a different way of thinking.
Everything from politics to geek culture to current events that polarize us as a society, we explore multiple ways of looking at things.
Welcome to this week's show.
We're really excited to be here with Stephen Mays to talk a little bit about, well, when we first met him, the topic that he shared with us, hijacking gene replicators.
So, Stephen, you can tell us a little bit about yourself.
Yeah, so I'm a medical laboratory scientist. Basically, that's the person that all the samples you get collected from a doctor come to. We do all the testing on it and give values to the physicians and other providers so they can make diagnostic decisions. And one of the departments that I work in is molecular diagnostics, where we do the bulk of detection of viruses, HIV, HCV, influenza, all the other things like that. And we use a technique or a modified technique of PCR, which basically is we're hijacking the way a cell replicates its own genome so that we can have it replicate specific target segments that we want that are unique to a bug. So we can see if the bug is either there or not there without having to grow it. And so it makes it a little bit quicker in that sense versus growing a virus and shell cultures can take up to a month versus PCR. We can have results, inside hours.
Well, and I admit that when this whole thing fired up, you were on a very short list of our friends that I was like, I wonder what he's up to in all of this.
Yeah.
Because
being busy.
we talked, when we first met, we talked about the flu and how you were involved in testing around that sort of thing. And I'm like, well, this has to fall into that realm. So I guess the first question is, what have you been up to?
Yeah, we've been ramping up our testing for not just COVID itself, but respiratory viruses altogether, streamlining our workflow, taking away some of the bacterial workups that I was doing on my shift so that I can focus pretty much solely on viral respiratory illnesses right now. We've brought on 4 different unique test systems specifically for COVID-19. We're probably going to have a 5th relatively shortly here. And we're really working on increasing our bandwidth where we were, able to run, under 200 a day to now we're working on ramping up into the thousands so we can meet the demand in Colorado.
Yeah. So, and I think this should just be fascinating for our listeners, but what is the process in general for what you do?
As far as actually testing the sample itself?
Yeah. Where do they come from? Like what was your normal daily life and how is that kind of changing?
Yeah. So normal daily life, I mean, in a hospital itself, you have a lot of your work that comes in from your inpatients and then from the emergency department itself. But also, especially as you get into larger health systems, we'll take in the samples from all the doctor's offices, local clinics, freestanding emergency departments, and work up those samples. So we test a huge cross section of the population in general. But because of the ramp up of this virus, we've been having to specialize and close things down, especially with the numbers that we can test to just our health system and just our hospital. So as we started bringing on COVID testing in our labs itself, instead of sending it out to an outside facility, we've been testing emergency room patients with respiratory symptoms and new admits to the hospital, as well as healthcare employees. Yeah. And so pretty soon here, as we ramp up, we'll be able to bring on those doctors' offices again that we have been working with. So, and then hopefully in the long run, being able to test asymptomatic people as well that may have been exposed in any sort.
So what's your exposure or safety protocols in terms of, one of my really close friends is a respiratory therapist and she was showing me the gear she has to wear. I was like, wow.
Yeah. And respiratory therapists are a heck of a lot more exposed than people in the laboratory because they're directly with the patients. They're breathing the same air. They're in very close contact. In the laboratory, we're kind of insulated, number one, by that distance from the patient itself, but then also by the equipment we have in the laboratory. We have biological safety cabinets, which are like a negative flow pressure hood that we work in, and then with HEPA filters so that as the air comes out, it's cleaned and brushed of any virus and stuff like that. So we have a lot of the same personal protective equipment, PPE, the gloves and face masks and lab jackets and things like that. But we have a little bit of extra safety by distance, number one, and then extra safety equipment we get to use. So our exposure in the lab is a lot less than a lot of the front lines, the respiratory therapists, the doctors, the PAs, the NPs, the nurses, the CNAs. All these people have like a way higher exposure than I do.
Gotcha.
Yeah, I feel like labs are generally, like, precautions are taken, but they're generally a much more controlled environment. So
yeah, they typically just stick us in the dungeon and are happy with that.
Right.
Like, that's so. And then
once in a while it ends up paying dividends.
do you also work on like vaccines, or do you know? I'm just wondering. We hear a lot about different potentials for vaccines for COVID-19, and the timelines like 12 to 18 months, which I know sounds like a long time in some ways, but feels really fast. And
it is super fast. They are fast tracking a lot of these things in that sense. I don't work a ton with vaccines. I'm pretty familiar with them. I'm not an expert by any means, but I can definitely make sure that the basic concepts of it are established, and I can speak to that. But as far as the vaccines, most of the part is just I get them because I'm in the hospital, so they make me.
Right.
So I get poked. Yeah, I get poked a lot, but I mean that's fine. I'd rather be protected than not.
Yeah.
I'm a firm believer in vaccination itself. The concept is sound and proven. It's funny that we get these huge anti-vax movements, and it's partially because of the success of vaccines, because no one knows how miserable it is to have polio. No one knows how miserable it is to lose a child to smallpox. These are things of the past. In a lot of real senses, it's not that they can't come back, but these are the things of the past. And when they're in the past, you become desensitized to how horrible it is.
Yeah.
I'm imagining some of the anti-vaxxers will probably change their opinion once a vaccine for this does come available.
And this could be like a paradigm shift in the way that people look at vaccinations. If a really strong COVID vaccine comes out and is really effective, you might be able to put a little more people into the realm of, this is a good thing. This is something we need to work on and work with instead of trying to just ignore. Especially when you think about herd immunity and the immunocompromised that can't take vaccines. Dependent on the bug, they need a huge percentage of the population to be protected in order to protect them.
Yeah, I know some countries initially said they wanted to go for herd immunity and figured they would just deal with that, but
and then the projections were so horrific they had to shift.
Absolutely, yeah, and and that whole concept of we'll just write it out. There's bugs you can kind of do that with, and there's bugs that it's best to err on the side of caution. This did come at us a little bit out of the blue. In a lot of ways, we should have got on the workhorse a little faster. I personally, when it first came out, I was like, this is going to be like SARS, or this is going to be like MERS. It's going to be something that's not super transmissible. We'll pay attention to it and see what happens. And then it's starts snowballing. You're like, uh-oh.
Well,
this has got potential.
Yeah, that's an interesting point. I'm curious. So what was the timeline for you? When things started to shift? I'm sure in January you were just testing for the flu, right?
Yeah, and we've had a really weird and pretty intense flu season as well. So that was kind of where the main focus had been at. And when it started coming out and getting a little bit of information about it, understanding it's a coronavirus. So I was making comparisons to human coronaviruses, and then also the unique ones like MERS and SARS. And so I was like, well, what's the toss up of what it is? If it does travel really well with humans, maybe it's more like the ones that already infect humans and it's not a big deal. If it doesn't, maybe it's more easily to be contained than SARS or MERS. And this thing kind of sits in the middle of those. So it has to be treated differently. It's easily transmissible, not nearly as deadly case by case basis. But if you infect a heck of a lot more people, you end up having a death toll that's a lot higher.
Right. Well, and that I feel like that's a really important distinction that for my watching the sort of movement of our awareness of it was that early on there was, I want to say early March, which so honestly it feels like it's been 7 years that we've been dealing with this. So when I'm like, oh, 2.5 weeks ago, but
every day is a marathon currently.
Every day is like so long. But I was reading things that were talking about how it was asymptomatic and still contagious, unlike many things that we deal with. And what was really interesting to me was that the CDC at that point still had that you were only you were only contagious if you were symptomatic, and then it's like you might be if you, and so that to me was an indicator that we had a real problem. That there were these admittedly like early term reports that hadn't been vetted fully, where they were positing, we're pretty sure you are contagious before you're symptomatic, and you might be more contagious before you're symptomatic. And our CDC wasn't even pushing that out there yet. And so I was like, oh, this is, I don't know how this is going to go.
There's really interesting things where this virus is tending to travel further down the respiratory system the longer you have it. And so we're starting to have a concern and looking into people that when they have a nasal pharyngeal swab, and that's when they shove the Q-tip all the way back to your brain through your nose.
Mm-hmm.
It's not super pleasant, but so that's where we're testing to pick up the virus from.
Yeah.
And we're starting to see with some people, especially as they develop the pneumonia from this, is that we're no longer recovering the same volume of virus in the nasal pharyngeal cavity as we are lower in the respiratory system and into the lungs as the disease progresses. So these people may even have the potential of testing negative on a nasal pharyngeal swab, where they may test positive if you were testing further down the respiratory tract, like a bronchial, BAL, like a bronchwash.
Wow.
Yeah, so that's a new real concern that we're starting to look into as well. And so we're even, allowing providers to repeat testing on COVID with some people if they're really strong inclinations that this is what's causing their issues. And then we're telling them to try and get a sample from lower in the respiratory tract system. So if we can see that this actually is holding true or not, or if this is something that we need to pay attention to. So these things are very dynamic, and a lot of information comes out real fast, which makes misinformation a lot easier to stick, and a lot harder to find what's real, because what's true one day is not necessarily the next.
Yeah.
That, I think, kind of defines this whole thing. And I mean, it's so weird to have such a shared experience. I mean, I talk to people in Australia, they're in the same shutdown. It's the same exact thing. Like it's everywhere around the world. But yeah, the other thing about this that's defining it is like every day they're like, that thing we said, it's not exactly true. We're actually thinking this new thing. And like, wow, okay, that sort of shifts and explains why an entire state.
And I think a lot of it has to do with tangibility, right? When it's so far away and it's no one it's not really tangible. You're like, that doesn't affect my everyday life. And then all of a sudden there's one case in the US and you're like, there was one Ebola case in the US that was brought in. We're fine. And it's it's 15. Oh, it's 150. Oh, it's this entire nursing home.
Yeah.
It's not until it actually gets to your state or gets to someone, that you really start taking it seriously. And these kind of things are the things that you have to address them well before you're actually scared of them.
Yeah.
By the time you're actually scared of them, it's typically way delayed from where you should have been moving on things.
Yeah, it's one of the things we were talking about. For whatever reason, this caught my attention, and we were actually sort of paying attention and trying to prepare and having conversations with people who are like, oh, I don't want to panic. And I'm like, precaution is not the same as panic. And actually,
Absolutely.
Panic is what happens when you deny there's a problem and then you wake up and realize, oh gosh, like, there's a big deal. And if everybody took precautions, the downside of that is that if we actually caught it early and took precautions, there's a possibility of it not ballooning. And then people are like, oh, see, you didn't have anything you have to worry about. Like it does.
I feel like
right. Well, yeah, it naturally flattens the curve if you take precautions early, right?
Yeah.
And that's the whole thing that we're talking about, and that is just like, if you look at Italy, they have people that are dying from this disease that didn't have to had they had the equipment available at the time,
or even the bandwidth
manpower available at the time, right? So that's what this flattening the curve is all about. It's not about getting less total number of people infected. It's about getting them to come into the hospital when the hospital can still take care of them.
Yep.
Right.
Yeah.
That's what we're trying to do. We're past the point of, oh, we're going to stop this from spreading. Like that point's long gone. That boat sailed a long time ago. It's already on its way back to China, where their cases are coming in from out of country.
Yeah.
Right. We're past the point of containment. We have to look at the concept of how do we make this the least lethal possible.
Right. And the least suffering.
And that goes with the social distancing, making sure hospitals can get equipped, get them the equipment they need, and getting a vaccine out there as fast as possible. And then we also need to be looking at people that recover from this disease. Can we use their antibodies to help people that are also really sick? Can we take those COVID antibodies out of them and put them in someone else who's, really close to dying? Can we get effectiveness from that? There's a lot of talk with the anti-malarial drugs working. Yes, we need to test them. No, I'm not sold. It's anecdotal. That doesn't mean it's not going to work, right? But it means we need to look at these things first before we just start releasing them to the mass public.
Yeah.
I think the public has this idea that,
health consequences.
Right, because I think the public has this idea that, it might help, so pump me full of it. But it's like, nah, there's side effects, there's things you don't want. Like, I know those malarial drugs have some wicked side effects. Like, they're not...
they can be lethal.
Yeah, they're not given out lightly. But they're given out if you're dying of malaria. In fact, the testing that we have is basically people at death's door that they're like saying, well, it's worth a shot.
Yeah, there's a great historical case study, if you will, that kind of follows along this lines. And it was, I think it's pronounced Thalamid was one of the names it was sold under. And it was a drug that was created in Germany, I do believe. And it was used to treat insomnia, anxiety,
thalidomide,
and then they started pumping it. And then they started pumping it out for morning sickness, right? And it was hailed as this miracle morning sickness pill. It had zero side effects. Everything was great. The Europeans approved it for use in people. It was sold over the counter in some countries, right? And the U.S., we had 11 people employed at the FDA that were in charge of all drug approvals. And one of them, Frances Kelsey, she put her foot down and said, no, so we got to study this harder. We can't release it yet. And she had done work previously with anti-malarial drugs, funny enough, and found out that some of those anti-malarial drugs cross the placenta and can affect the developing fetus. And she had the same fears about this. Pumped the brakes on it. And then it became used for, I think, in 61. And then in 62, a study found out that all these kids in Europe were now being born without limbs.
Yeah, the children of thalidomide. Yeah, totally. Yeah, I remember that.
And like 40% of them died.
Wow, that's heartbreaking.
We have to study these things before we just release it to the mass public, because unforeseen consequences by getting too eager too quickly can be catastrophic.
I don't know why I'm familiar with that story, but I totally am. But we'll post a link in the show notes to the story of the children of thalidomide. It was a big deal for a very short time, because luckily, and this is one of those really sad cases, it was so dramatically bad. They were like, oh, stop right now. And so it
only took gestation to figure out that there was an issue.
Yeah.
Right.
And then
within
so
9
if you
months,
have a mother that takes it as at the beginning of her second trimester, then you're going to have results in 6 months.
Yeah.
And then you have to start following the correlation. Well, it's like, okay, is this correlated or is this caused?
Right.
Because it's also, you don't want to jump the gun and say something is at fault when it's not.
Yeah. Well, and to quote a certain thing out of the context of what somebody said, the cure can't be worse than the disease. And so in this case,
there's a proper context for that, for sure.
Exactly. In this case, we don't want to necessarily jump on things. Look, if they work, I'm all for it, but we got to be careful.
Right. It's a balancing act.
Yeah, that's why we do the science. Mm-hmm. That's why the science is the concept of removing emotion from the equation.
Right. And getting
if you're emotional about something,
if
you have a predestined idea of what you want to happen, then you're not going to do it properly. You're going to make flaws, even subconsciously, that are going to lead you towards your conclusion that you want.
Yeah. So before we started the show, you were talking about some different viruses and how they compare to the boogeyman of today. And it was very
Yeah.
interesting. So I'm wondering if you'd be willing to give our listeners a little overview.
And get sciencey, because I want people to want to look this stuff up.
Yeah,
Yeah,
like it's
absolutely.
super
So
sciencey.
there's a lot of talk out there on Facebook and the other social medias that this is just the flu, or it's just a mutated flu. When we look at the actual structures of the virus, it's such a ridiculous statement that it's even out there. They're both like RNA viruses, so they don't have any DNA in them. They keep all of their genetic material on RNA. And the way that the coding is on the RNA, when a coronavirus RNA enters the cell, it can be immediately transcribed into functional proteins. Okay, and so that's called positive sense. It's directly done by itself. With the influenza family of viruses, they're negative sense. So their RNA needs to be transcribed into a different copy of RNA, and then have that copy transcribed into the functional protein. So they replicate in completely different formats, even though they're both RNA viruses. So the idea that it's just a flu, a different type of flu, is a complete misnomer. And then if you also look at the length of the genome, the coronaviruses, I do believe, are the largest of the RNA virus family, or enveloped RNA virus family. And their genome is basically twice as long as influenza virus genomes. So, I mean, that would be a heck of a mutation to double a genome, right?
Yeah.
And turn it into the opposite route and make another step for replicating when it doesn't, versus its copy of its genes. So it's, there's a lot of misinformation on that sense, but this is a different virus. It's not completely, the family of viruses is not new to humans at all. There's several strands of coronavirus that are we test for, and they're just like the common cold. 229E, I think HKLE1, and then OC43 are like the serotypes that are the most common in humans as far as respiratory illness. SARS and MERS are also coronaviruses. So it's a very dynamic family of viruses. It's not new to humans, even though this specific one is, or it looks like it is.
So if our common cold is a coronavirus, is it just so different that it doesn't give us any advantage in fighting this off? I mean, like, why do we care that they're the same? Does it have any impact on our ability to deal with it?
Yeah.
Yeah.
Yeah. So the most part of that is more on the academic and the diagnostic side of things.
Gotcha.
Because you can see there a lot of virus families have a lot of things in common. Like if you look at Ebola and Marburg, they're both in the same family. They both cause hemorrhagic fevers and are, among the most deadly, per infection rates, the highest infection or death rates per infection that we see, the lethality. Whereas you look at the coronavirus family and it's everything from, 40% kill rate to, you shake it off, that everyone goes to work with because they're like, oh, it's just a cold, right? It can have that range. So having them all in the same family is a little bit more on the academic diagnostic side than it is about like symptomatic for the general public.
Well, now I have seen this, and I'm assuming this is one of the more labby scientific terms called like something SARS-2. Are they essentially equating it?
So the SARS is a severe acute respiratory syndrome. That's what that acronym is for. And that was caused by a coronavirus. So it's SARS-CoV-2, so coronavirus number 2. So the second coronavirus that causes this, even though, I'm not sure where you would classify MERS is on that, but that's kind of irrelevant. It's all in just naming, but it is important to keep some historical record of naming things similar that are similar.
Mm-hmm.
Yeah. Well, and I mean, that to me was the biggest argument for the as I'm now calling them, COVIDiots, that assume this is nothing. It's like, no, they actually called it SARS-2. Like, let's just put this in perspective. Yeah,
we went from novel virus from Wuhan to COVID-19, which is coronavirus infectious disease, I think. And then 19 for 2019 is the year it popped up on the scales. Like people forget that it wasn't January.
Yeah.
And then as we started seeing that we were getting similar respiratory illnesses from it, then they rolled it into SARS-CoV-2.
Mm-hmm. So
I mean, it's just one of those, things that are going to change every day until we dial it in.
Yeah, and I think the key there is that we need it to just be able to identify and talk about it, but hopefully we won't need too many more.
Yeah, but
of
in the
these
same
names.
sense, you don't want to confuse people. You don't want people to think that COVID-19 is different than SARS-CoV-2, right? So you run that real risk too.
Yeah,
just in like the general perception of the public.
So one thing that I would love if you're able to offer it is suggestions for where you would consider to be good sources of information for people to go to. Like you said, there's just a lot of not
Tons
super accurate information. And I will say, like, when I started reading about this, because it hadn't caught the public's eye, I found that actually I could get pretty good source material. And now I'm completely overwhelmed. I have very little idea of what's what's solid and not. It takes a lot more time to wade through it than it did. And I mean, I definitely have like the, Reuters, AP kind of thing, but just from a medical, biological perspective, like what are the places that are, accessible to the public that you trust or would think have a good chance of being at least helpful?
The first thing I would say is definitely caffeinate before you go to these websites. They're scientific papers, so they're really tough to read as far as the boredom level goes. But like the NCBI government web base has some great papers. I would suggest to people that really want to figure out what's going on with it to actually just do some background research on the different types of viruses, like the differences between influenza and corona, as far as some of the research that's been done on them, because that's where we first go when we have a novel virus. We're like, okay, we have this virus, it's corona. Let's go to the research that we have to see what we can assume and then test to prove if that's right.
Okay.
And so we always got to start with our background. NCBI website is good, but you have to sift through a lot of research papers. The CDC website is relatively up to date. Where our health system, like the numbers come in from all different types of labs that are testing for it. We're more a little bit delayed on accurate counts than other countries are because they're all through one system, right?
Okay.
So we're always going to have a little bit of delay on that. And then the second thing is look at some of the university health systems that are doing work with this, like University of Washington. They're doing groundbreaking work. They're the first to develop their own novel test system for it in the United States. They dealt with an extremely bad rapid outbreak very quickly. There's a lot of information coming out of UW right now that's really solid and groundbreaking.
Great.
As it is, feet to the fire, papers getting written coming out of there. Like things are flying off the shelf.
Necessity is the mother of invention.
Absolutely. And that's a really good, a strong university system. So they, we're kind of lucky in the sense that assisted living center was in Washington.
Yeah.
It was in the greater Seattle area. Yeah. Just because of that. If we look at how fast San Francisco snapped down and went on lockdown, I was actually in Sonoma County the day before I flew back to Denver. The cruise ship docked in Oakland, right?
Yeah.
That shutdown, being gutsy enough to do that saved lives. Absolutely. And when you look at like San Francisco's numbers versus New Orleans, you're going to see a huge difference, especially as the next 6 months come through. And you're going to see the difference between being overly cautious and you're going to see the difference between waiting until there's a problem.
I think Florida's about to be on that on that list very soon.
And they're not going to do anything to contain it. They're absolutely not.
No.
I mean, until they back off the religious services, you have large groupings of people that shake hands and hug, people in close contacts with each other, people singing, breathing deeply, right? Standing next to each other, shoulder to shoulder. Like that's showing to be just a breeding ground.
Did you see that terrifying article about the choir practice in like northern Seattle?
Absolutely. Breathing deeply, singing.
Yep.
And then all of a sudden, boom, a couple people in your choir are dead and like half of them are sick.
Yeah. So as we get towards winding down here, I wanted to touch on something more personal just because we're kind of collecting these stories and sharing them. As a medical
Sure.
professional, what's your home life like? What are you guys doing to stay safe? And
Yeah, my home hasn't been this clean in a long time. I love it. Uh, it's been great. It's funny how you kind of, like, the moral inventory they talk about with AA and things like that, you kind of do in those kind of situations when you get gut checks like this. You're like, man, how long has it been since I've cleaned the door handles on my front door? That's gross. Like,
yeah,
you start going through these things. You're like, maybe that needs to be reworked into the daily routine a little more. Like, not necessarily scrubbing every door handle every day, but like being prudent with it.
yeah. I would guess.
So
that's,
for the most part, it's been my work week, where I work a week at a time, 7 on, 7 off. My work week is focused on showering, eating, working, sleeping. That's it. I cut out all my extracurricular activities. I don't run errands. I don't do laundry. I get all that done, especially currently. Like, I have a bag in the trunk of my car with extra scrubs and a toothbrush, basic toiletries in case we get locked down at the hospital and I have to stay there a couple of days. So you make those adjustments as far as my work week. My off week, trying to self-isolate, being a good citizen, looking out for my neighbors, right? I have some elderly neighbors that live next door. When I see the wife will go walk her dog around the block, I'll ask her if she needs me to pick anything up at the store for them. This is, especially considering how polarized our country is, this is a really great time to find some common ground with people by just being human.
Yeah.
I completely agree. I think it's, I have said this numerous times, and I am still really impressed with, in general, what society is actually doing when pressed. I did not necessarily have faith that it would go like this, and it has been pretty good.
Yeah, and it's, we're definitely coming up on the hardest weeks for this country are in the near future. Obviously, that varies by location. A state like Idaho is not going to see the worst of theirs for a while, and they're already on lockdown, so that's good.
Yeah.
But a state like New York, we're not too far behind. We're like 5th or 6th, I think, in states. I'm not sure exactly on the numbers where we stand right now.
We're 14th. I look every day.
Oh, good. That's awesome.
Connecticut
That's way
passed us
better
yesterday. It's like,
small place though.
yeah,
Like,
they're
those places
densely
are gonna-
populated. So
Yeah. So, I mean, we're not too far behind. The Metro Denver area is starting to explode. If people keep taking this seriously and keep looking out for their brothers, and their neighbors, we could see drastic savings like San Francisco can.
yeah.
But if we think around, we're going to end up like, downtown Brooklyn right now. We're going to end up like, the French Quarter. It's not going to be pretty.
Yeah.
Yeah.
It's not the worst thing that we've ever seen, and it's not the worst type of pandemic humans will ever face or have ever faced. We're kind of lucky in that sense that this is serious enough that we have to take it serious, but it's not, it's not like the exposure of smallpox to Native Americans.
Yeah. Or if it had a death rate of 10% or something ridiculous, right? Like,
yeah, absolutely. So we're lucky in a sense that it's not way worse, but it is bad enough that, like, there's significant damage from it.
Yeah.
I think we're going to be feeling it for a while, but yeah.
And what's going to be really interesting to bring up, like, I know I've talked a lot about not comparing Corona to flu, but I'm going to.
Okay. Well, you're allowed.
Yeah. What's known as the Spanish flu, which I think we've kind of nailed down that it came out of the Midwest of the United States, but war times, countries protect their information a lot closer. So that flu hit in the spring, like early spring, flu season, and it killed a bunch of people. But it wasn't until it came back in the fall that it really started to take out people in mass.
Yeah.
Right?
We
so
just don't have the data if this is going to be a seasonal thing.
We have to play the game like there's going to be a rebound in the fall.
Yeah.
If we don't play the game that way, if it does happen, it's not saying that it will, right? But this is one of those, let's treat the sky like it's falling on that aspect.
And prepare for it.
I think my one bit of comfort in all of this is that warmer countries right now are having just as bad of a time, which is leading me to think that hopefully it doesn't really care about the temperature.
right, that it doesn't become a swinging disease, like heads north to south and then back up.
Right. Like it's been
which is
global.
how you see like Australia's flu season is opposite of ours.
Exactly. It's, I mean, and Australia has had just as much going on right now, and it's their summer.
Yeah,
so.
and there's some things coming out that humidity helps drop it out of the air faster, so it doesn't stay hung in the air that everyone else is breathing longer. I'm not too sure about any of the validity into that, but it's something to look into for sure.
I'm going to start walking with
especially where it's one of the larger viruses too.
I'm going to start walking with a spray bottle.
Like, just walk with
walking around with a spray bottle. Yeah, this is like a humidifier curtain.
Exactly. No, I did some research because I was curious, and the numbers are approximate, but the Spanish flu killed in its first evolution in 675,000 Americans, and 290,000 Americans died in World War II. 116,000 died in World War I, and about 60 in Vietnam. So those are our numbers, right?
Well, and here's the other thing: is you have to think about as society is who you're willing to lose, right? There's a big part of that of an acceptable death in a war, a soldier dying. People are desensitized to it in a certain aspect, right? Because you have a clear defined enemy and you understand that it's ugly and people die, right? With things like pandemics, when you're not fighting a person, when you're fighting a disease, it's way different because the people that die aren't necessarily the people that you expect to die as a society.
Right.
I know that the focus has been on, the elderly are hit really hard by this, but that's not saying that there's not 30-year-olds on ventilators right now.
Oh no,
right?
like I think that's the worst myth that got propagated was that only old people would die of this.
Old people
or have it badly. Yeah.
And they're a more vulnerable population. The next two things that are the highest on the list is like diabetes and obesity. And look where our country's at.
Yeah,
we have a very large elderly population. We have a ridiculous amount of diabetes, especially type 2. We have a huge weight problem in this country.
Yep.
And these are the people that are most likely to end up on ventilators.
Yep.
Now, we have friends on ventilators. We have a friend that could not get tested. She's had it for 2 weeks. And the friend that was on a ventilator moved into ICU. They moved him out because he was okay the next day, but he's still in the hospital dealing with it.
He's our age. He's
yeah, he's like our age.
And then there's concern about long-term lung function too.
Yeah.
Whether or not your lungs are going to be able to rebound back to 100% after this a lot of that is in question.
Or even
too.
how long it would take.
About lifelong debilitation.
Yeah.
It's not looking like it's something like you have to be in an iron lung like polio, but I mean, still that. We have to think about that cost to us as well.
Did you like going on hikes? Because maybe you can't now.
Yeah, exactly. Like, you like Denver? Too bad. You need to live below 2,000 feet.
Yeah. That's really true.
Well, here's hoping that it all turns around, and thank you very much for the work that you're doing. I mean, I know it was your job anyway.
We sign up for it. I'll thank a healthcare worker though. I like the push that's been going around about wiping out student loan debt for all first responders and healthcare workers. This is our GI Bill, basically, if you looked at it that way, because this is our war we're fighting.
Well, I will say that I appreciate you being out there every day and helping.
And thanks for taking the time to explain some of this stuff. I really appreciate it. And I think our listeners will appreciate it too.
I think a huge part that science actually misses out on a lot is reaching out to the public and the community, kind of letting them know what we're doing.
Yeah.
Totally. Well, we'll kind of keep your number on file. Hopefully we won't have too much to talk about more, but maybe we'll have you back on.
Yeah, absolutely. Oh, we could always nerd out about other things though.
Oh, yeah, that's true.
I want to do that. You know what? I mean, you don't appreciate what you have until it's gone, but I'm like, God, there's so many other things I wish we could just be talking about right now. 2020 just went sideways on us.
Yeah, really rapidly too.
No, it's true.
So, stay safe, and we'll try to have you on as this progresses. Hopefully, you won't be slammed, or maybe it'll let up. Maybe locally, especially in Denver here. So.
Absolutely, no, I'd love to be coming on here talking about how we've turned the fence and how things are looking good and what we did right.
That'd be awesome.
Obviously, also things that we did wrong and things that we can improve on, because we should always be self-critical as well. But I would love to be like, here's the good news. This is, how we're doing this. This is where the virus or vaccines are at in testing and, all those things. Like I'm hoping that we get to those things really quickly.
Yeah. Me too. So, well, thanks. And we'll talk again soon.
Yep. Thanks.
Yeah, absolutely.
Thanks for listening. If you have ideas, feedback, or thoughts, please find us on social media. We are BiCurean on Facebook, Twitter, and Instagram. Or email us at podcast@BiCurean.com.
And if you like what we're doing, please rate us on your listening platform of choice.
Thank you.